Overview of Methods. In the previous section, the physiology and some of the relevant research regarding FABMs was described. This section will explain how that information has been applied to develop these methods of family planning. Specifically, we will review cervical mucus, symptothermal, and symptohormonal methods, as well as the standard days and lactation amenorrhea methods. First, though, we'll begin with how the evidence is evaluated based on the Strength of Recommendation Taxonomy, or SORT criteria. In order to appreciate the effectiveness rates of FABMs, it is important to understand the strength of evidence supporting this data. Family physicians and primary care clinicians evaluate the strength of evidence based on the Strength of Recommendation Taxonomy, or SORT criteria. This criteria allows us to assess the quality and consistency of available evidence. The quality of evidence is determined by the study design and the outcomes measured. For example, Level 1 studies would be prospective cohort studies or randomized controlled trials that measure patient-oriented outcomes. The second component used to determine the strength of evidence is the consistency in results across different studies. For example, are the typical effectiveness rates of a specific intervention or treatment nearly the same in different studies? Based on the quality and consistency of the research, the strength of recommendation for a body of evidence is determined. An A recommendation signifies there is good quality patient-oriented evidence shown in multiple studies. A B recommendation typically signifies the evidence is of limited quality or findings are inconsistent across studies. A B recommendation is also assigned if there is good quality patient-oriented evidence from only one study, which is commonly the case with these methods, as limited research has been done on FABMs. A C recommendation signifies the evidence is disease-oriented or based on consensus opinion rather than well-conducted research trials. As you will see, all modern fertility awareness-based methods are level A or B. You should be aware that a review article published in the Osteopathic Family Physician explains the SORT criteria for FABMs in detail. Let's now turn our attention to the group of FABMs that are based on the observation of a woman's cervical mucus.
Cervical mucus methods rely only on the observation of a woman's cervical mucus or fluid secretions. These are sometimes called ovulation methods because most of these methods indicate when a woman may ovulate. There are a few different cervical mucus-based methods. The most well-researched are the Billings ovulation method, Creighton model fertility care, and the 2-day method. All three methods are based on observing the presence or absence of cervical fluid secretions at the vulva. Different methods require a different level of detail regarding these observations. The Billings and Creighton methods identify the fertile window, so they can be used to both achieve and avoid pregnancy. We can also add to this group the Marquette method, which technically is a symptohormonal method, but has a mucus-only protocol with evidence to support its effectiveness. Please take a moment to view the unintended pregnancy rates in the graphic. When couples use just this one sign of fertility correctly, they can reliably avoid pregnancy. Note that with typical use, the effectiveness rate is comparable to other user-directed methods of family planning, such as the condom or the pill. Billings ovulation method. In the early 1960s, Drs. John and Evelyn Billings of Australia developed the Billings ovulation method, the first cervical mucus method and the first modern FABM. Throughout the day, women tune into the sensation of mucus at the vulva. This is the Billings method most important observation. They can take more detailed observations, such as looking at the mucus on a toilet tissue, but they do not have to do so. Since women can sense a tiny amount of mucus at the vulva, sensation is a reliable parameter. At night, women will chart the most fertile sensation felt during the day, and if mucus is observed, they may record that as well. Women use their own words to describe their observation. Note that this diagram shows examples of Billings charting. Here is an example of a Billings chart for one cycle. Let's discuss how it works. A woman notes her cervical secretions and represents them with either a stamp or a symbol. On this screen, we show both. A woman also notes the sensation at the vulva and anything else she considers important. It is important to note that the number of bleeding days, dry days, and days of mucus buildup may vary. In this example, after menses ends on day 5, estrogen is low and the woman will probably feel dryness at the vulva. As estrogen levels rise, her sensations at the vulva will change, usually from dry to damp on day 10 here. This indicates that her fertile window is opening. Her sensations will become wet and slippery, and the visual appearance may become clear approaching the peak day, which correlates closely with ovulation. Peak day is the last day of the slippery sensation, which can include the appearance of slippery, stretchy, or clear mucus. Here, that is day 15, because the mucus changes from the slippery sensation, or the stringy, slippery, and clear mucus on days 12 to 15, to dry on day 16 because of elevated progesterone. The fertile window closes at the end of the 3rd day after peak. This is because research shows that ovulation occurs 98% of the time within 2 days of peak. Since the egg can survive for up to 24 hours, a woman could theoretically conceive up to 3 days after her last day of peak-type mucus. If a couple wishes to avoid pregnancy, they can resume sexual relations on 4 days after the peak day.
Creighton Model Fertility Care System. Another cervical mucus method that is similar to the Billings ovulation method is the Creighton Model Fertility Care System, or Creighton Model, developed by an OBGYN, Dr. Thomas Hilgers, and his colleagues beginning in the 1970s. As with Billings ovulation method, the user characterizes and records the presence and quality of cervical mucus. The Creighton model, however, uses a more specific and detailed approach to these observations, following the acronym SOFT. A woman notes the sensation at the vulva, observes mucus on the tissue, and finger tests for mucus quality. There is also a very specific methodology and vocabulary for recording these observations that is different from the Billings method. Like Billings, the Creighton model identifies the peak day, which is the last day of peak-type mucus that is stretchy, clear, and/or lubricative. It is generally considered the day of highest fertility, as it is right around the time of ovulation. Creighton is more detail-oriented and requires precise training for both the instructor and couple. Its universal and standard recording system allows a Creighton-trained medical consultant to know what symptoms women are describing throughout her cycle. In fact, some patterns of cervical mucus or bleeding may suggest certain pathologies. This has led to the development of a new approach to women's reproductive health care. This promising new approach to women's reproductive health care is called natural procreative technology, or NaPro technology. Using NaPro technology, Creighton-trained medical consultants can use information ascertained from Creighton charts in conjunction with appropriate medications and surgical procedures to evaluate and treat infertility, endometriosis, and other reproductive problems. NaPro technology has shifted the paradigm on women's health. Rather than suppressing or disabling a woman's fertility or masking the symptoms of an abnormal cycle with hormonal contraceptives, such as the pill, the Creighton Model Fertility Care System allows a woman to gather more data on her cycles and work cooperatively with a Creighton-trained medical consultant to understand her reproductive health and try to address underlying problems. The 2-day method is the simplest cervical mucus method to learn and use. Researchers at Georgetown University's Institute for Reproductive Health developed it as part of its global effort to mainstream fertility awareness based methods of family planning and bring them to large public health programs. In the 2-day method, the woman checks each day to see if she has cervical secretions or not. That's it. Quantity and quality do not matter. If a woman sees cervical secretions, she simply notes it. Using the Institute's teaching aids, this method enables a provider to easily teach the 2-day method in a single 20-minute visit, no matter the level of the patient's education. The 2-day method is not designed to potentially identify ovulation, so it is less informative than the Creighton or Billings methods. But it can still be used to identify days of potential fertility and help couples avoid pregnancy. This illustration shows how a woman uses the 2-day method. She asks herself 2 questions every day. First, did I note secretions today? Second, did I note secretions yesterday? If she notes secretions of any type today or yesterday, she should consider herself potentially fertile and has a chance of getting pregnant if she has sexual intercourse today, hence the name 2-day. When a woman does not note cervical secretions today or yesterday, she is unlikely to become pregnant if she has sexual intercourse today. Then the next day, she repeats the questions.
Welcome back. We will now turn our attention to FABMs that combine cervical mucus observations with at least one other sign of fertility, the symptothermal and symptohormonal methods. There are many groups that teach a symptothermal method. Two of the most popular that teach the method according to the criteria evaluated in the effectiveness studies are the Couple-to-Couple League and Northwest Family Services SymptoPro. The best-known symptohormonal method is the Marquette model, of which there are different versions. These methods teach cervical mucus observations, but they also have the user check for other markers of fertility as a cross-check to more clearly define the fertile window. A woman, therefore, records these markers on a chart and can find the fertile window and the infertile times of her cycle. Since these methods identify a fertile window, they can be used to avoid or achieve pregnancy. These cross-check methods have strong evidence supporting their effectiveness and are also comparable to hormonal contraceptives at preventing pregnancy. The first cross-check method is the symptothermal method, or STM. The symptothermal method combines 1. Cervical mucus observations plus calendar guidelines to identify the beginning of the fertile window, and 2. Basal body temperature to identify the end. Remember, when progesterone rises after ovulation, a woman's basal body temperature, or BBT, increases notably and reliably. The BBT helps clarify mucus observations and shows that ovulation has indeed occurred. A woman using STM can also add observations of the position and softness of the cervix. However, this sign has not undergone the same amount of rigorous testing as mucus and basal body temperature, so it is strictly a secondary observation. Cross-checking two studied symptoms of fertility may give couples more confidence in their identification of their fertile window. Here is what a typical symptothermal chart looks like. Of note, some STM charts include cervical fluid observations at the top of the chart, whereas others, like this one, show the cervical fluid observations at the bottom. To track her fertility signs, a woman takes her BBT with a basal body thermometer at the same time each day before getting out of bed. At the end of the day, the woman records her cervical mucus observations, both sensation and characteristics, using the most fertile reading of the day. In phase 1 of the cycle, a woman does not typically observe any cervical fluid, and her BBT is lower than at the end of the cycle. However, change is what matters for the basal body temperature, so the mucus or fluid observations are most important right now. The onset of cervical fluid indicates that phase 1 has ended and phase 2, the fertile period, has begun. When the basal body temperature has been elevated for 3 days and the peak day, indicated by fluid changes, has passed, the fertile window has closed and phase 3 has begun. Since the temperature peaks after ovulation, it's a retrospective indicator, but it can help clarify mucus observations. If pregnant, the woman can observe her chart to know which day she ovulated, and then identify the estimated day of conception, which may be very important in later obstetrical management. It is much more accurate than the LMP gestational age estimate, especially in unusually long or short cycles. Cervical observations are optional. The cervix rises higher in the pelvis and softens and opens as estrogen rises. It often changes a couple days before changes in cervical fluid, but at times may lag behind. Palpating it discovers very early indicators of approaching fertility. Symptohormonal, Marquette model. Now that we've discussed symptothermal methods, let's take a look at symptohormonal methods by reviewing the Marquette model. In the Marquette model, women use a handheld battery-operated device called the Clear Blue Easy Fertility Monitor. This monitor is used to measure the woman's estrogen metabolite and luteinizing hormone, or LH levels, present in her urine. The monitor indicates the level of fertility on the day tested by measuring the amount of estrogen metabolite, or E3G, and LH from the woman's urine. These observations are secondary to cervical mucus observations, the other sign in the cross-check method. With the Marquette model, a woman can also track other signs of fertility, such as her basal body temperature that we discussed previously in the symptothermal methods. An advantage of the Marquette model is that the woman can learn the entire method online and track her daily observations online as well. Here is an example of the online charting system. It reflects a woman's recording of her cervical fluid observations and the electronic hormonal fertility monitor's reading. Notice that the monitor indicates 3 levels of fertility based on the hormonal reading and cervical fluid observations: low, high, and peak. High fertility begins when the monitor detects rising levels of estrogen metabolites in the urine and as mucus becomes thin and watery. Peak fertility begins when the monitor detects the surge in LH right before ovulation, and when the mucus becomes slippery, stretchy, and/or clear in appearance. The fertile window is closed when estrogen is low and mucus has thickened up. Researchers have also developed a simplified form of the Marquette method that entails a simple fertility algorithm and use of either the hormonal monitor or cervical mucus as a means to estimate the fertile window. This method can be taught in a 12 to 15-minute office session or self-taught online. A randomized comparison of the monitor versus mucus observations showed a significantly lower typical use unintended pregnancy rate with a monitor, 7 per 100 users over 12 months of use, versus 17 with mucus. Now, let's discuss a modern, reliable calendar FABM that has been tested in clinical trials. The Standard Days Method, or SDM, is a simple FABM that uses a standard algorithm to determine the possible fertile days in women with regular cycles. The SDM always identifies the same fertile days for every woman. These days are identified based on understanding the fertile period in women with regular cycles of 26 to 32 days. That might sound narrow, but 75% of women have 26 to 32-day cycles, and 75 to 90% of all cycles fall within that range. The SDM is therefore suitable for a majority of women. The Standard Days Method identifies days 8 to 19 as the 12 fertile days in the cycle. This period starts early enough for women with short cycles and extends long enough for those with long cycles. The World Health Organization considers the SDM a modern natural method of family planning because it's based on sound understanding of reproductive biology, follows a precise protocol for correct use, and has been tested in appropriately designed studies. Even with typical use, the SDM is far more effective for avoiding pregnancy than barrier methods. For example, condoms have an 18% failure rate with typical use, whereas the SDM has an unintended pregnancy rate of 12 per 100 woman years. Here is an example of the cycle beads that a woman may use to track her menstrual cycle with the SDM. Do you see the black rubber ring on the brown bead at about 2 o'clock? On the first day of menstruation, the woman places the black rubber ring on the red bead and then moves it forward each day in the direction of an arrow indicated on the strand of beads. The beads have a color code. The red and colored beads indicate days that the woman is probably infertile. The white beads indicate the woman's potentially fertile days. The beads are a simple, reusable means for a woman to track her cycle, showing her days that she may be fertile.
Lactation-based method. Although most of the fertility awareness-based methods described so far may be used by women who are breastfeeding, let's now take a look at a method that is designed specifically for women who are breastfeeding. This FABM is the Lactational Amenorrhea method, or LAM. A woman may use this method for the first 6 months after giving birth if she is exclusively breastfeeding her baby and her period has not returned. Effectiveness rates are very high with this method, greater than 98% effective for both typical use and correct use. Exclusive breastfeeding has numerous benefits for both the mother and child, and therefore should be strongly supported. That a woman may also be able to effectively postpone pregnancy when fully or nearly fully breastfeeding is an added bonus.